It is my honor to introduce our keynote speaker for today, one of our Komen scholars, Dr. Dawn Hershman. She's professor of medicine and epidemiology and director of the breast cancer program of the Herbert Irving Comprehensive Cancer Center. Dr. Hershman's expertise includes breast cancer treatment, prevention, survivorship, late effects of cancer therapy, health outcomes, and health disparities research. A clinical scientist, Dr. Hershman's research interest focuses on understanding ways to improve breast cancer outcomes by identifying factors that are associated with suboptimal breast cancer therapy and conducting clinical trials aimed at predicting which patients may be more susceptible to experience either treatment or financial toxicities related to their breast cancer care. Dr. Hershman investigates overuse of procedures and drugs with uncertain benefit to the patient. Her Komen Scholar grant focuses on better understanding of the impact of comorbidity, such as diabetes and hypertension, on complications and outcomes of cancer therapy, on breast cancer outcomes, including toxicity, survival, and healthcare utilization, and how clinical trials can be generalized to avoid an underestimation of the true efficacy and toxicity in the general population. We wish that Dr. could have been here with us in person. Unfortunately, due to weather and flight cancellations in New York City, her flight was not going to happen, and she wasn't able to travel across the country to be with us. However, with the power of technology, we're very grateful to have her with us via video and across the state of Oregon. So I want to welcome Dr. Hershman, and I please ask you all to join us in a very warm Oregon welcome to Dr. Hershman.
So I hope you can hear me. Thank you all so much for inviting me. I'm very disappointed that I couldn't be there in person. There were electrical storms out of Newark, so they grounded all planes. So I'm there with you in spirit. I really love being at Komen events, and I'm very, very grateful to all the work that Komen does. And I'm going to be talking today about some of the work that Komen has funded for us to do. And so, again, thank you so much for the invitation here today. As I said, as the speaker mentioned, a lot of my focus is on healthcare outcomes in breast cancer patients and ways of improving the survivorship experience. So, as many of you know in this room, one of the most important personalized therapies we have for breast cancer is hormonal therapy, and probably the most important hormonal therapy that we have are aromatase inhibitors. Hormonal therapy is the most effective way to reduce recurrence in patients with early stage breast cancer. Aromatase inhibitors have become the standard of care for postmenopausal women. This has been since the initial presentation of the ATAC trial comparing aromatase inhibitors to tamoxifen in postmenopausal women. We've learned over time that not only is hormonal therapy important, but taking it for longer periods of time seems to provide a benefit. We've learned that 10 years is better than 5. As of recently, we've even learned that even if you're not postmenopausal, taking aromatase inhibitors along with suppressing ovarian function can be effective. And aromatase inhibitors are not only important for the treatment of breast cancer, they're also important for prevention. They've been shown to be effective for ductal carcinoma in situ, as well as for the primary prevention of breast cancer. And they're in just about every guideline for prevention, treatment of DCIS, and treatment of early stage breast cancer, as well as metastatic breast cancer. But What we also know is that drugs don't work in people who don't take them. So oral therapies can be complicated because in order for them to work, patients need to take them, and that can be very challenging. These are results from one of the early studies we did, starting to look at whether or not women actually take their hormonal therapy. And we had done a lot of work looking at chemotherapy and factors that resulted in women not initiating chemotherapy or completing their chemotherapy. And then with a really wonderful collaboration we had with Kaiser Permanente in Northern California, we decided to look at administrative data in women that were on hormonal therapies. And what we found at the time was that in this cohort of over 8,000 patients, that over the course of the 5 years, about 25% of patients stopped taking their medication altogether at some point, and about 25% of patients were not taking it, what we say 80% of the time. There's long literature about what you need for efficacy, and 80% seems to be the cutoff. And so, taken together, only about 50% of women complete the full duration of therapy greater than 80% of the time. And this was pretty eye-opening to us because these are the same numbers that you see for other health conditions, but we assume that if this was something that would prevent your cancer from coming back, that women would take it. So then we started to ask ourselves, well, what is the impact of not taking your medication? What are the effects? And what we found from observational data, so these are cohorts of women that just decided to stop or decided to continue, that women that continued their medication had a lower risk of recurrence compared to women that discontinued their medication. And that was true for both breast cancer survival as well as overall survival. And we started to say, well, is there a dose response relationship? Like if you take it less, is there less of a response versus if you take it more? And we found, you can see with these red bars that the less you take it, the higher your risk is that the cancer will come back. So we know that it works. We know that from the randomized trials, but we know in the community setting that people don't take them, and not taking them seems to impact outcome. One of the problems with these kinds of analyses is that sometimes there's an inherent difference between people that take their medications and don't, that doesn't have anything to do with the efficacy of the medication. So we're always, try to present these results with some caution, but it's led us in a variety of different directions. So one of the best ways to know that it's not just the behavior, but actually the medication noncompliance that has an effect is to look at prospectively in patients on clinical trials. And we were pretty reassured when we saw the results of this study that came out in 2016, because it showed sort of the exact same things that we had found in observational data. Now, they calculated their adherence score slightly differently than we did, but these were patients that were enrolled in trials, and they looked at pill counts. And they found that patients that took their medications less had a higher risk of recurrence, and not just overall survival, but disease recurrence. So suggesting that the not taking the medication had a direct impact on breast cancer outcomes. So then you start to say, well, okay, if patients don't take their medication or they're stopped early, what are the reasons for that? And the reasons sort of fall into three big buckets. Cost is one, behavior is one, and toxicity is one. And in our research group, we've looked at all of these. So in terms of cost, we conducted one of the first studies looking at the effect of copayments. And what we were able to do is look at insurance claims data. We used uh, Optum for these analyses. And we found that as women had to pay more out of pocket costs, their likelihood of being adherent went down. And so you can see here, this is a proportion that discontinued their therapy, that even small changes, $10 to $20, can make a big difference for some people when they have to pay this every single month. We then were able to sort of look at a natural experiment because somewhere in 2010, all three aromatase inhibitors went from being only brand name to brand name and generic. And we were able to ask the question, well, if you start on a generic medication as opposed to a brand name medication with a lower cost, are you more likely to stay on your medication? And we found that that's actually true, that women that start with lower copayments are more likely to adhere to their medications. So cost seems to have some impact. And it's not just cost, it's actually how much money you have to pay. So they go hand in hand. So a patient's net worth can actually be assessed, and it can be calculated from administrative data based on some, pretty interesting things like how many houses you have and whether or not you have second home or what kind of car you drive. And a lot of things that are sort of collected from the internet can be used to ascertain roughly what somebody's net worth is, and how much money you have contributes to your likelihood to stay on medication, even above and beyond the copayment. So if you have competing costs that you have to pay for, like your rent, then you may be less likely to adhere to your medication. So we know costs make a difference, but cost is something we can actually do something about through either public policy or making drug prices lower, more accessible. Um, we've also spent a lot of work looking at toxicity, and we know that a big um, a one of the most common reasons why women stop taking their medication is because they develop side effects. And it's not just developing side effects, it's whether or not those side effects are recognized, whether or not they're managed, how aware the providers are of patients' symptoms, and how well patients are able to communicate those side effects that allows for management and patients' ability to adhere to their medication. So side effects play a major role. This is a study we did right when aromatase inhibitors came out on the market, because these medications were billed as being, the be all and end all. They had less side effects supposedly than tamoxifen. They didn't cause blood clots. They didn't cause endometrial cancer. But when we started to give these medications out, patients would say, "This medicine makes me feel like an old lady. I can't get out of a chair. I can't move. I'm tired. I can't keep taking it." So he said, "Well, this isn't what we saw in clinical trials." And the reason we didn't see it in clinical trials is because clinical trials are structured to really look for severe side effects. So we decided just to ask. We asked 200 patients consecutively about their side effects of joint pains and joint stiffness. And about 50% of patients complained of having some kind of arthralgias on these medications. About half was new onset, about half worsened. They had symptoms, but it got worse on the treatment. And the symptoms were associated mostly, they described pain and stiffness as being a result. So people have looked at those side effects and whether or not those side effects result in discontinuation. This is data from Big 198, which is a randomized trial that looked at patients on tamoxifen, either sequentially with letrozole, an aromatase inhibitor, or given essentially 4 different ways. But the take-home message was that a substantial number of women stopped even when they were on a clinical trial. And women were more likely to stop on the aromatase inhibitors than on tamoxifen when stopping early was from an adverse event or side effect. So you can see the numbers here. And generally in clinical trials, the numbers are lower than what we see in the community. This is another study that looked at time to discontinuation. I think the thought was, well, is there a difference between the different types of aromatase inhibitors? The yellow here is letrozole and the blue is exemestane. You can see slightly more discontinuation with the exemestane from toxicity. But I think more importantly, the majority of women that stopped were because of adverse events. And the most common adverse event was joint pain or stiffness. So, in addition to toxicity, which we've looked at interventions to improve, how patients' perceptions of their medications also seem to impact their likelihood of staying on. And we, again, in collaboration with Kaiser Permanente, were able to ask patients at various different points in their treatment a variety of different questionnaires that tried to assess their quality of life and their satisfaction with their care. And what we found in terms of the association between these things and discontinuation rate or adherence, that patient satisfaction, patients that had high satisfaction were less likely to discontinue their treatment. Patients that thought that their cancer was effective were less likely to discontinue their treatment. Patients that had better quality of life were less likely to discontinue their treatment. However, patients that had more symptoms that we would say are consistent with post-traumatic stress or anxiety about their diagnosis, about recurrence, were actually more likely to discontinue their treatment. And one of the biggest factors of discontinuing your treatment was whether or not doctors explained clearly why they were taking their medication. So that's something that these are all factors that we have the potential to intervene on. So they're important to know. So in doing some of this, we started to ask ourselves, well, is there a kind of person that has or is non-adherence to aromatase inhibitors? Are you more likely to be non-adherent if you were non-adherent to other medications for your chronic conditions? So the first thing we did was look at patients that were on other medications at the point that they were diagnosed with breast cancer. And lo and behold, patients that had a history of non-adherence to their antihypertensives or antilipidemics or diabetes medicines were less likely to be adherent. So if you're not adherent to your hypertension medicine, it predicts non-adherence to hormonal therapy. And conversely, if you're very adherent, you're more likely to be adherent because we want to try to see if we can identify patients at highest risk. And we looked at this in terms of people that were just on one other medicine or 2 other medicines or 3 other medicines. And if you're really not adherent to all of your medications, then you're even less likely to be adherent to your aromatase inhibitors. And converse is true as well. So the more medications you have, but more importantly, the more medications you have that you're not adherent to, really puts somebody at high risk for being not adherent to their hormone medications. And conversely, we also said, well, what happens when you're diagnosed with breast cancer, what happens to your other medications for your chronic conditions? Do you still take them if you're adherent beforehand? So we looked at a cohort of patients from claims data. We used market scan data, and we looked at patients that beforehand were relatively adherent and to see what happened after they were diagnosed. And as you can see here, adherence to your medications for chronic conditions goes down after a diagnosis of breast cancer. And this is true even if you take out the period of time of treatment and radiation and surgery, because maybe during chemotherapy, people are not adherent for other reasons. But even if you look at the year after that, you can see that patients become non adherent. And it really started to worry us, and it made us start to look at this issue in a lot more detail. So this sort of leads me to talk a little bit about the work that was funded by Komen, which was based on a lot of that work we had done already. And the first thing we looked at was the association between cardiovascular risk factors, cardiac events, and outcomes in breast cancer patients. So if somebody's presenting with a lot of comorbidities up front, what is their likelihood of having an adverse event? Because some of the risk factors for comorbidities overlap with the risk factors for developing breast cancer, such as diabetes and obesity, lack of physical exercise. And so, in addition, a lot of the treatments we give have cardiac effects, such as anthracyclines or trastuzumab or radiation to the left side of the heart. Those things can also influence cardiac outcomes. So we wanted to sort of look at that overlap. So I'm very involved in the NCTN and SWOG, which is one of the NCTN sites. I think the group chair's office is here in with you in Portland, Oregon. So it's an area that we're really work hard to try to get patients on clinical trials to move the field forward. But once a patient's enrolled on a trial, not only do they provide information on the results of that trial, we create a lot of data from these patients. We were able to link women to their Medicare claims to really learn a lot about other outcomes from treatments. And so what we did was we examined all of the patients that had been enrolled in SWOG breast cancer trials from the period of 1999 to 2011. And through claims, we were able to identify who had diabetes and hypertension and high cholesterol. And we were able to then take their clinical trials data to look at issues related to disease-free survival and toxicities and things that you need to collect prospectively on clinical trials. So what we found and what was published in JCO was that looking at cardiac events amongst patients that were enrolled in clinical trials, you were more likely to have a cardiac event over the course of time if you had a baseline cardiovascular risk factor. And we sort of assume that to be the case, but we didn't know the magnitude. So you can see if you have diabetes or hypertension or coronary artery disease, but importantly, the number of cardiac risk factors you have, as it goes up, your risk of having a cardiac event goes up as well. So it's important to pay attention to cardiovascular disease in breast cancer patients, actually in all patients. It's important. And this was particularly true in women that were on adjuvant clinical trials. So as we went up in the adjuvant studies, you can see this dose response based on having higher cardiovascular risks. But what was also interesting is that the number of baseline cardiovascular risk factors is associated with survival and seems to also be associated with progression free survival, albeit to a lesser degree, and with relapse-free survival. So this suggests that, as we might expect, that especially with overall survival, that cardiovascular disease is an important morbidity, and it's something we need to pay attention to. And what we were seeing is that patients that were diagnosed with breast cancer sometimes focus so much on their breast cancer that they stop paying attention to the management of their other comorbid conditions. And that the reality is that for some women that have early stage disease, you're actually still much more likely to die of cardiovascular disease than of breast cancer. So we wanted to bring that out to people's attention. And we started to think, well, okay, we had looked at non-adherence to cardiovascular medications, and we know that women are at high risk. What if we look at this in more detail? And we looked at a linkage between all of the SEER sites and their Medicare claims, and we looked at patients with early stage disease. And our goal was to try to see, again, if we saw that patients were non-adherent, just like we had done in our initial study, but what the effects of that non-adherence were. So we looked at women that were diagnosed with breast cancer, and we looked at the period of time, 1 to 2 years after diagnosis. And we wanted to define what factors were associated with non-adherence to other medications and see whether or not non-adherence was associated with having cardiovascular events. So these are some of the results. The first, we had a cohort of 15,000 patients that were had at least one cardiovascular disease risk factor before their diagnosis of breast cancer and were adherent to at least one of those medications at the time of diagnosis. And what we were interested in seeing was what the rate of non-adherence was amongst these women. These are women that were taking their medications beforehand, and what proportion stopped taking their medication once they were diagnosed. And we found that about 17% following a diagnosis were no longer adherent to at least one medication. About 19% of patients that were adherent to their antihypertensives became non-adherent. And you can see down the line that becoming non-adherent to your diabetes medication was the highest amongst all the comorbidities. And we went through and looked at factors, what factors might be associated with this change from becoming adherent to non-adherent. And getting chemotherapy was associated. How many comorbidities a patient had was associated. Having a higher stage and having hormone receptor negative cancers was also associated. So patients that were the most concerned about their breast cancer had the highest risk of becoming non-adherent to their cardiovascular medications. And so then we asked the question, well, what's the impact of becoming non-adherent? And these are hazard ratios for the likelihood of having a cardiovascular event if you were non-adherent to each of these medications. So becoming non-adherent increased the odds or the hazards of developing a cardiovascular event by about 30% if you were non-adherent to your antihypertensives, 20% for antilipidemics, and 30% for non-adherence to diabetes medications. And this is the same information shown graphically. And this is the time to developing a cardiovascular event in those patients that were adherent versus those patients that were non-adherent. And you can see highly statistically significant differences between these groups in terms of the incidence of having a cardiovascular event. So the last thing we looked at, and this is data that we hope to be presenting at ASCO this year that was also funded by Komen, we went back to look at that clinical trials database and said, well, what else happens to women that have comorbidities if they're on a clinical trial? Can we get a sense if they use the healthcare system, if their costs are the same compared to women without comorbidities, and what factors might be associated with that? And here you can see this is looking at healthcare utilization in terms of emergency room visits or hospital stays. And as somebody has an increased number of comorbidities or cardiovascular disease risk factors, uh, we looked at what we had, which was diabetes, hypertension, obesity, and high cholesterol. We didn't have smoking in these patients and we didn't have family history. But as you go up in the number of cardiovascular risk factors, you see a marked increase in terms of the odds of either ending up in an emergency room or ending up in the hospital in that first year of treatment. This shows also how the costs of care associated with breast cancer and how it increases with increase in cardiovascular risk factors. And this is the percentage increase in cost compared to somebody without this risk factor. And you can see here it broken down by hospital stays and emergency room visits. As you can imagine, that if you have more times where you're going to the hospital or an emergency room, the cost associated with that goes way up. And with 2 or more cardiovascular disease risk factors, you have almost a 50% increase in costs. So we also were interested in how representative this was, because this is amongst patients that are enrolled in clinical trials. And to be enrolled in a clinical trial, if you have comorbidities, they have to be relatively well controlled in order to meet the eligibility criteria. So we decided to look, well, how does comorbidity affect your likelihood of even being placed on a clinical trial? And so there's been a lot of emphasis in the news and the media and the FDA and ASCO and ACS and Komen about all the different things we can do to try to get more patients on clinical trials. And we found that some of the strict eligibility criteria that we put into trials really has a big impact in preventing patients. So we used data that we had from a large web-based survey of cancer patients to look at how clinical trials affects being offered trials and their decision making and ultimately their clinical trial participation. And here you can see this is comorbidity and clinical trial accrual. This was published just about 2 months ago in JAMA Oncology. It actually got considerable amount of press. And what you can see here is that the more comorbidities you have, especially if you have more than one compared to none, you're less likely to be offered a discussion about participation in trials. You're less likely to be offered a clinical trial, and you're significantly less likely to participate in a clinical trial. You can see what the differences are in terms of the percentages that actually participate. And what we were able to do is, look at different factors and the odds. This is the same information presented a slightly different way in terms of whether or not you have no or more than one comorbidity, and your odds of participating or being offered a clinical trial ranged from 10% less to 12% less, straight down the line. But what was interesting is we did some modeling and we were to say if these exclusions weren't there, how many more patients could we get to participate? And we found that if we took these basic comorbidity exclusions out of the clinical trials, we'd have 6,000 more patients going on clinical trials a year. And that just speeds the process of discovery, allows us to get new treatments to patients faster, and allows patients who want to participate in trials. And so, you know, a lot of work is being done now to change this and to change these policies for inclusion criteria. So what we want to do next with all of this information is to say, well, okay, we want to make sure that we can make patients aware of their comorbidities, make sure that they know that adhering to their medications and managing their other conditions is important. So we started to think, how can we intervene? And so what we're trying to do now is look at whether or not medication adherence applications can actually improve both medication adherence for breast cancer, like their hormonal therapies, as well as medication adherence for their other comorbidities. So we've learned from other disease states that medication assistance apps, when given to patients with cardiovascular disease that have had a cardiovascular event, not breast cancer patients, that they can increase the likelihood patients will stay on their medications, and decrease the number of patients that are low adherers, meaning low adherence to all of their medication. There's been studies in patients with hypertension that shows that a medication adherence app can improve self-reported adherence, and that in a cohort of patients with antihypertensives looking at really complex ways of measuring adherence, you can actually increase adherence rates compared to patients prior to their medication app by just making people aware that these apps exist. So people say, well, what are you talking about? What is a medication app, and what do they do? So there are commercially available applications that you can download. The one that we're studying is called MediSafe, and they can be downloaded on your phone or your watch or tablet, and they can will ask you, send you text reminders when it's your time to take medication. Information can go up to a cloud. It can interact with your specialty pharmacy, so you know when it's time to fill your prescriptions. You can also program it so that it alerts a caregiver if a medication's not taken, and you can also program it so that it alerts your provider if medications aren't taken, so that your whole healthcare team can be made aware. And this is how it can look on your phone. It can provide information on what the benefits are of the medications, why you're taking them, when you should take them, and provide visualizations to help with that. And so what we're doing in our group in SWOG is asking the question if use of these medications, and not just downloading it on a patient's phone, but really providing patients with a team, if they choose to have a caregiver or their office physician or a nurse be part of their team, and to provide with updates and instructions to help engage patients and see if this helps people understand the importance of taking their medication, and not just their breast cancer medications, but all of their medications. So we hope to be doing this study over the course of the next year in SWOG. So the trial goals will be to see if this really inexpensive and widely available tool can help patients manage their complex medications, but also to see if it helps increase communication between patients and providers so that we can understand if somebody stopped, why they're stopping, and see if there's a way we can intervene. So, just to summarize, a significant portion of women are non-adherent to their medications for breast cancer. They're also non-adherent to their medications for chronic conditions. Being non-adherent to breast cancer medications is associated with worse breast cancer outcomes, and being non-adherent to cardiovascular medications is associated with worse cardiovascular outcomes. As breast cancer survival improves because we make so many new discoveries and have such great medications, it's really important for providers and patients to be aware of cardiovascular risk factors so that we can work on trying to reduce them. And as I said before, our future studies are going to address interventions to improve adherence to all of patients' medications to improve their global health and well-being. So I'm going to end here and open the floor for any questions.
Thanks, Dr. Hershman. If anyone in the room would like to ask a question of Dr. Hershman, we've got some volunteers in green shirts that will be happily take your cards. There are note cards in the middle of your tables with some pencils. Please write them down. And if you are at a simulcast site, please type it in the chat box, and we've got a committee member who will write them down for you.
We're going to trade out. Cindy's needed in another part of the room. Is this a question here? Thank you. One of the questions is, can you talk more about the MedSafe app, if I'm reading that correctly?
So the MedSafe app is actually free commercial. I'm not here to advertise for it, so but it is free for patients. It's been used in a variety of different studies. It's actually easy to use. Before I decided to study to see whether or not it would help patients or whether or not we could figure out ways to help patients, I downloaded it on my phone to see how it works. And you can, it's actually really very easy to use. You can plug in all of your medications and it'll give you a little alert when you're supposed to take each one. It's actually can be programmed to interact with your specialty pharmacy or if you're a major pharmacy to let you know when you're about to run out of medications. It's complicated and difficult to manage multiple different medications, and we need to help patients figure out better ways to do it.
Thank you. How do you assess the effect of having comorbidities on the efficacy of a drug being tested in a clinical trial?
Excellent question. One of the things that we want is for our clinical trials to be representative so that we can say, okay, you have comorbidity X and you're this age and you have a tumor that's this big. How well does this treatment work for you versus treatment A versus treatment B? And the only way we can answer that question is by making sure that all patients can participate in clinical trials with lots of different backgrounds. So sometimes when clinical trials exclude patients, we use large administrative data from big organizations like Kaiser or CancerLink or other insurance-based claims to try to answer those questions in other ways. But we look specifically to see, if there are drug-drug interactions in preclinical studies.
What is the information available regarding Latino patients as far as treatment adherence?
That's actually a big interest of mine. We're in the process of doing a lot of pilot studies at our institution. One of the things with the MedSafe app is that it's in various different languages. And we know that Latina women can have a higher rates of comorbidity in general. We've found in studies that minorities in general have less adherence, but actually, interestingly, if you correct for the financial factors, some of that difference in adherence goes away.
Doctor, was age a factor? Excuse me, was age a factor that was considered in the studies?
Always a big factor in terms of adherence. A lot of the studies we had to do in order to get the data sets, we needed to link to Medicare claims. So in the studies where we linked to Medicare claims, patients were automatically in those cohorts over 65. So it was harder for us to look at younger patients. But I can tell you that younger patients have a much harder time being adherent to hormonal agents. They have a less of a likelihood of being on other medications for chronic conditions, but have a harder time being adherent to hormonal medications.
The follow-up question was age range for these trials. Did I hear you say it was over 65?
On the study that we did in terms of what the data was. Some of the studies we did included all ages, and some of the studies we did only looked at women over the age of 65.
Thank you. Next question, has there been any programs to provide cell phones to people without the ability to pay for cell phone or monthly services, for example, the aged or low-income patients?
Not that I know of. I don't know of any programs that do that, other than some states have programs to provide phones to people in low income, but I'm not sure if they have the ability to download apps on those phones.
A translated question that I was given was, which people or populations have the most risk to suffer cardiovascular diseases?
Disease is linked to high blood pressure. It's linked to diabetes, obesity, high cholesterol, history of smoking, and family history. We know that ethnic minorities have a higher rate of all of those factors, and so as a result, there's an increased risk of metabolic syndrome and a higher risk of cardiovascular events.
Thank you. We have time for just a couple more questions before we break. The next question is, what are your thoughts on breast cancer Lodex for women with many toxicities?
So in terms of increasing adherence to medications if they have toxicities, I guess I want to make sure I'm answering the right question.
I don't have anything more. If there's the person out there that asked the question.
Lost
Yes,
the sound.
Dr. Page?
There was a lot of beep.
Breast cancer index? Oh, okay. Sorry, couldn't read your handwriting, David. My bad.
I'm sorry, I missed that question.
The question that Dr. Page had was, what are your thoughts on breast cancer index for women with many toxicities? Did I say that correct, David?
That's a really, really interesting question. So, and an important one. So there's, some genomic tests that have been developed, and there's some, data that suggests that you can predict who's going to benefit from longer term hormonal therapy versus shorter term based on their risk of recurrence after 5 years. So amongst women that at the 5-year point, to help decide who should stay on their treatment for longer versus shorter, sometimes you can use the breast cancer index. And in a woman that has a lot of side effects, if that genomic test shows that they have a low risk of recurrence over the subsequent 5 years, maybe the benefits aren't worth the toxicities from taking the medication.
So I'm going to finish with 2 related questions before we break. What is the difference in effectiveness between an AI and tamoxifen? And is there any data yet on efficacy of AIs after 10 years?
You know, there's a statistical benefit of aromatase inhibitors versus tamoxifen, but the biggest benefit is taking some type of hormonal therapy versus not taking any. And so sometimes we can lose track of that. And that's why it's important to know that tamoxifen is an outstanding hormonal medication, and the side effects are different than the aromatase inhibitors. And for some patients, they're much more tolerable. And so the differences between the two are teeny tiny compared to the benefit of taking something over nothing. So it's always important that if you don't tolerate, you know, an aromatase inhibitor, that then you consider trying tamoxifen.
Thank you for the questions from the audience. And I want to thank you, Dr. Hershman, for joining us. Though we missed having you here physically, we so appreciate you giving us an hour of your day from the East Coast, and are very grateful for the information that you shared. And I hope everybody will join me in giving you a round of applause. You can hear us. You can't see us. So we will now... I'm sorry?
Sorry, I couldn't make it there.
Oh, we absolutely understand. Thank you.